Good evening, sir. Abhishek.
Abhishek, good evening.
Good evening, sir. Shall we start? Good evening, sir. Shall we start?
Yeah.
Thank you so much, sir. So, on behalf of Corona Remedies, Arush Division, I invite you all for the E-Prime Time, this Core Connect live show. The first show, live show on the endometrial preparation for the FET. For the program, our guest of honor is Dr. Shanta Kumari, who is President FOXI. From her blessing, we have conceptualized the event. Dr. Shanta Kumari, currently she is president in FOXI. She is senior consultant and ob-gynae laparoscopic surgeon in Hyderabad. She is chairperson in Indian College of Ob-Gynae, ICOG FOXI from 2018 to 19. She is secretary in TCOGS from 2017 to 19. She has initiated DHIRA, a social medical campaign to eliminate the violence against the women. Chairperson for the event is Dr. Fassi Lewis. He is Vice President FOXI. Currently, he is working in Amrita Institute of Medical Sciences, Cochin. As I said, he is Vice President FOXI. Apart from that, All India FOXI International Academic Exchange Committee Chairperson from 2013 to 15. He is Secretary General All Kerala Federation of Obs and Gynae from 2012 to 18. Apart from that, he is Vice Chairperson of Kerala Chapter IAG, Vice President KFOG. Thank you so much, sir, for your presence. I hand over to you, sir.
Good evening to all of you. So first of all, respected FOXI President, and for this concept and to the Corona Remedies for this wonderful initiative. The importance of today's topic is the speaker itself. Speaker is Dr. Kundan Ingle, who doesn't need any introduction because he is the Infertility Committee Chairperson of FOXI. He is IVF consultant of Nirmati Clinic, Pune. And to tell he has the award of the best research paper in ISAR 2019 second, and in 2018 and 2019 lot of awards FOXI and ISAR he has got, and he is the, as I told, director of Nirmati Clinic, Center for Assisted Reproduction Endoscopy, Pune, General Secretary of Pune Obstetrics and Gynec Society 2019 to 20, founder treasurer of Maharashtra chapter of ISAR, and founder member of Pune Association of Endoscopic Surgeons, and presented research paper at ISRM 2020 and on the prospective randomized control trial on estradiol valproate versus estradiol hemihydrate in FET, frozen embryo transfer. Director of MOSCS Basket IRT Bank, Pune, presented first time research at 6th Kogi World Congress at Vietnam on use of GCSF, colony stimulating factors, in subcutaneously for thin endometrial. And today's topic, the importance is that if you compare with about 20 years back, Then we had for frozen embryo transfer, we had only the I mean slow freezing, that is a slow freezing technique. Then over the last 10 years, the vitrification is evolved. The difference is that by vitrification, the number of oocyte or the embryos which can be I mean coming out of the frozen state, that is known as thawing, that the retrieval rate is very high. So the net pregnancy rate of one ovum pickup is increased. That is, if we per se take the IVF, and especially if there is hyperstimulation, we can freeze the embryos. We can go for antagonist protocol with agonist stimulation, freeze the embryos. Even otherwise, when we freeze, the chance of hyperstimulation is less. Initially, when we started the practice about 22 years back, we were really afraid, because the freezing technique, the number of embryos surviving after the freezing and thawing was less. So we had to depend on the fresh transfer. Now it is more, and we can conveniently eliminate or decrease the hyperstimulation. We can conveniently transfer that. Net pregnancy rate after one transfer is more, because more and more straws or can be thawed, and embryos can be thawed, and we can use in subsequent cycles. So the net pregnancy rate is gone up. So the net cost for one pregnancy, IVF pregnancy, has come down. So that is the importance of or the frozen embryo transfer in the present day practice. For that, the most important thing, other than the vitrification, is that how we will prepare the endometrium for the transfer, and that is a really critical topic for all infertility IVF specialists. So today we have an expert, Kundan Ingle, talking about that. He has got his vast experience, not only the academic but the clinical and practical experience. I hope will be very useful for all the practicing infertility specialists. At the end, you can put the questions, so we'll have a healthy discussion like that. Over to you, Dr. Kundan.
Thank you, Dr. Faisal Lewis, Vice President Foxy. Thank you very much for those kind words of introduction, and thank you for introducing the topic of today's presentation. Thanks to, at the onset, thanks to Corona Division and Corona Company for organizing this particular event and inviting me to speak on such a important topic, which is also of my interest. And respected guest of honor, Dr. Shanta Kumari, President Foxy. So friends, today we are going to learn about a lot of things about frozen embryo transfer and endometrial preparation protocol. So as Dr. Faisal has already introduced and said that a few years back, or maybe 6 or 7 years back, we used to always talk about optimizing IVF protocol. And that time we used to always talk about frozen embryo transfer, that how comparison with fresh embryo transfer, now frozen embryo transfer is giving us a better results. Now, after achieving a certain height of the particular success rate, which is maximum, now we get it in frozen embryo transfer cycle in certain group of patients. Now we want to learn how can we get optimization of success rate into frozen embryo transfer by concentrating on the endometrial preparation protocols. And I think it is one of the very important area, because these two steroids, that is estrogen, progesterone, everything, all protocols plays around these two particular hormones. And today I'm going to give you how to prepare with endometrium with estrogen, and whether it is endogenous or exogenous. Or also we are going to discuss about how much and should be the progesterone for the preparation of endometrium for the desodolization for successful implantation. So with this, just to give a small quote which means a lot thing, that perfection means not perfect actions in a perfect world, but it is appropriate actions in an imperfect one. Of course, I always feel that there's nothing called as a perfect work. It is way ahead of all of us. Probably we won't be able to reach till we call it as a perfect world. So it is imperfect one. But currently, whatever technology and science advancement are there, and that is what we have to learn, that how we can appropriate actions in current era to optimize our success rate. And for that, whenever it comes to frozen embryo transfer, I think the main topic which is below the sea level is the endometrium receptivity. So it is a ability of the uterine endometrium or uterine mucosa to facilitate successful embryonic implantation is called endometrial receptivity. And for that, you need a receptive endometrium, you need a blastocyst stage embryo, and there is a complex sequence of signaling events that are very crucial in synchronizing a dialogue between maternal and embryonic tissue. Now, we know that receptivity is something which is, it is a subtle collaboration between certain cytokines, those we call it as biomarkers, which are sometimes they are stimulated and implemented by embryo itself. So it is not only certain steroid which are inducing it, but it is also by the embryo also. Now it results into establishment of there is an accurate morphological and functional transition, and because of which this interaction which happens between embryo and the maternal tissue that leads to successful implantation. Now all that it started a frozen embryo transfer after this study which was in way back in 2007, which touched this hypothesis that if you have very high levels of estrogen in the circulation, then it has got associated with a decreased trends in implantation and as well as pregnancy rate. And that is why we started thinking that no, fresh cycles are actually not giving us the result which we are supposed to get it. Instead of having good embryo, I think there is something adverse event of this high estrogen levels on the endometrium. And since then we are working, all our scientists and all our fraternities working on this, that how can we improve fresh embryo transfer result, ultimately which leaded and made us understood in 2011 that evidence of impaired endometrium receptivity after ovarian stimulation in IVF, and whether this patients, when we subject them for a frozen embryo transfer, does it really improve the success rate? And when it calls success outcomes, then it is implantation rate, clinical pregnancy rate, and ongoing pregnancy rate. Now, for all practical purposes, ongoing pregnancy rate is the one which we are looking at, and that is something like a presence of cardiac activity at 12 weeks of gestation, and that is with frozen embryo transfer was 78% versus in fresh embryo transfer, which was 58.9%. And that's very significant difference into the, in ongoing pregnancy rate when compared with fresh versus frozen. And I think that opened our eyes that yes, if we accept this technology, that probably we will be able to go another 20% milestone, and we will be able to reach somewhere close to 100%, but still not 100%. But yes, with certain advancement in even frozen embryo transfer cycles now, we can actually really go and closer and achieve a success rate even beyond 80%. So impaired endometrium receptivity is apparently actually accounted for most implantation failures in fresh group. So around 64.7%, that was the attributable risk percentage of implantation failure due to inadequate endometrium receptivity in a fresh group. That was conclusion by this study. Now comes that, okay, we accepted this technology. Now how you will prepare her endometrium for frozen embryo transfer? And for that, I think there are more 4 types of protocols which we are going to discuss today. One is a modified natural cycle. Of course, this is a modification of natural cycle. So first protocol should be natural cycle. But now, since many years, we don't follow this natural cycle anymore. It is always a modified natural cycle for frozen embryo transfer. Now, second is ovulation induction protocol. Third is the artificial cycle by HRT. And fourth is a exogenous HRT protocol, similar like third, but only in a down-regulated cycle. So let's see what you mean by modified natural cycle protocol for FET. For that matter, I've combined these two flow charts of natural as well as modified. So here you start monitoring patient's follicular growth from day 9 of menses, where you also start monitoring the LH levels and by the urinary kits. And whenever the surge happens, you detect the day of ovulation, and accordingly you start the progesterone. Now, this was a natural cycle. Now, what is the modification in natural cycle? That we don't wait for the LH surge. What we do is we monitor the follicle, and as soon as the follicle is 18 millimeter, and if the LH levels are absolutely below 5 MIU per ml, then in that case, you give a trigger with SCG, either 5,000 to 10,000 international unit. And then you have basically with SCG, you have timed this ovulation. And from the day of ovulation, you have already started a progesterone. Now in this part of second half of progesterone, we will cover it in the second half of my presentation. But this was somewhere here we are dependent on a natural follicular growth. Now remember, this is only possible into regular menstruating women who has a natural spontaneous follicular growth or spontaneous ovulation. So these patients group are the one who can be subjected for modified natural cycle protocol. Now, second is ovulation monitoring cycle, that is ovulation induction cycle protocol for frozen embryo transfer. And in this particular protocol, what you do that you give either oral ovulogins, and if required, then you can add gonadotropins. But majority times now with availability of letrozole, this letrozole is given as a 2.5 to 5 milligram per day from second day for 5 days. Because of this ovulation induction drug, we have a follicular follicular development, which we monitor ultrasonographically. And once the follicle is 18 millimeter, you give a trigger by SCG, and then I'll call the patient after say 40 to 44 hours and confirm that she has ovulated, and then you can start progesterone, and accordingly further part can be managed. Now here we need to understand that why do we have to use drugs for ovulation induction, and the reason is that this protocol is designed only for those patients who are unovulatory. So we take the help of a follicle for endogenous estrogen production, and endometrium is developed in response to this endogenous estrogen coming from the developing follicle. So that's the second protocol. Now the third protocol, which is an artificial cycle by HRT protocol for frozen embryo transfer. Now here, obviously, the hormone replacement therapy, the name itself says that here the hormones are coming from exogenous source. So here what we do is right from the second day of menses, we start supplementing with the estradiol, either valerate or hemihydrate, 4 to 6 millimeter, which should be a starting dose per day. So BD or TDS of 2 milligram tablet. And then we increase the dose by 2 milligram every 72 hours. So at least for 12 to 16 days, at the end of this duration, we do expect the endometrium growth beyond 7 to 8 millimeter. And once the endometrium is developed, then we can start progesterone, and then we can schedule the embryo transfer. Now in this, we need to understand that even if you are giving a ovulation, HRT, that is hormones from exogenous source, remember, there are possibilities that these hormones may suppress FSH because it is estrogen. It will suppress the FSH, and because of which there may not be any follicular development. But it is not 100% in all patients. So sometimes it does happen that FSH is not suppressed well. So sometimes you do have even follicle developing at the same time when you are giving estrogen from outside. Now what happens if the follicle develops? Remember, this follicle is also producing estrogen, plus some estrogen is coming. There is always a possibility of LS surge, which you might miss, because here you want to give progesterone, but there is a possibility because there is no down regulation. So pituitary is not down regulated. So you will have to look for follicular development into this cycle, and remember, monitor that follicle. If the follicle reaches 18 millimeter, then if your endometrium is not sufficiently grown, or you are not happy and you still want to increase the exposure of higher doses of estrogen, then in that case, you'll have to give antagonist for sufficient number of days till you have a desired endometrial picture, so that you prevent a pituitary, you down-regulate pituitary and prevent the LS surge. Now, if there is no follicular development, then it is little safer side that you may not get. But remember again, the estrogen levels are coming up from outside. As soon as the estrogen level reaches to the threshold, here you can still get a LS surge from the pituitary, because again, it is a non-down regulated cycle. So there are certain areas where body intervention or woman's hormonal intervention we may come across, and that is why here sometimes that you will have to monitor LS levels. so that in case if you are going beyond 12 to 16 days. So remember, a patient who has a thinner endometrium and where you have a already elective plan that you want to give estradiol for many days, like 3 to 4 weeks, probably in this protocol, be careful, don't use this protocol and go for down-regulated protocol. Now this fourth protocol, which is again a similar HRT cycle, but you have down-regulated the pituitary. Now here what we do, the first part is that we have two options where we down-regulate. One option is that, and on day 21 of cycle, you give GnRH agonist depot 3.75 milligram intramuscularly. We know that this act for at least minimum for 28 days. So after 21st day injection of GnRH agonist, 11 days later, normally we expect a down regulation and patient should get her menses because she has an endometrium developed from previous cycle. Once she gets her menses, the next protocol is to give, the next part of the protocol is to give again estradiol valerate or hemihydrate, starting dose again 4 to 6 millimeter. You increase by 2 milligram every 72 hours and keep on giving till you get a desired endometrial picture. Now this protocol generally, you have a little luxury. Suppose you have a thinner endometrium, but you want to give a little for a better endometrial picture, prolong estrogen. That's the advantage because here you won't get LS surge because already you have down-regulated pituitary, and that's why we have a lot of advantages with this protocol. One is advantage is that first of all, you can plan your embryo transfer properly. You can schedule your embryo transfer properly. You don't need to, you have a full control on the cycle, which is not there in the modified natural cycle or ovulation induction cycle. And that's something where this protocol is very helpful. We are going to understand about the safety profile of each protocol. Now, in 2020, this effect of artificial cycles with or without gonadotropins releasing hormone agonist pretreatment on frozen embryo transfer. So this particular protocol that had patients who are undergoing HRT cycles without down regulation and another group of 303 who had down regulated. So what they realized that especially in those young patients who are less than 35 years, if you compare the clinical pregnancy rate, it is more better with a patient who received agonist, that is HRT in a down regulated cycle in comparison with without down regulation. Second group where this particular protocol helps is endometriosis, where again this study has given us a clear-cut evidence that clinical pregnancy rate and live birth rate in endometriotic patients are more significantly more and better with down-regulated cycle and HRT. In PCOS also they found that the miscarriage rate, which is very high with PCOS patient, it is very minimal with in PCOS patient because of the down regulation. It was 3% versus 16%, which was there in HRT without down regulation. So it looks like that young patients who are less than 35 years and endometriosis and PCOS, these patients are going to have a lot of help from this down regulation protocol. And this is something which we must learn from the evidence. Now, what is the optimal means? So we have 4 protocols. So this systematic review in 2013 wanted to study which is better, which is associated with maximum success rate. Is it with is some protocol is inferior to some other protocol? And that's what this review and meta-analysis concluded, that all of the current methods of preparation protocol, they appear to be equally successful in terms of ongoing pregnancy rate. This was in 2013. So we were very clear that if a patient has got a regular cycles, you can go for modified natural. If a patient is unovulated, you can go for ovulation induction or even HRT protocol. So a lot of things we can do according to the patient's menstrual history. Now this was in 2016, where a modified natural cycle was compared compared with artificial cycle in a frozen embryo transfer, and that was a randomized control trial, and was known by Antarctica trial. So what they realized that there was not much difference in terms of pregnancy outcomes, like even ongoing pregnancy rate between modified natural and artificial cycle. But one more very important point they brought up in this protocol, this paper, is the cycle cancellation rate. As I said, the cycle cancellation rate was much higher in modified natural cycle because there were many factors. Sometimes the follicle is empty, it has produced, it's a defective follicle. It has produced a very low estrogen levels. Ultimately, the endometrial picture is something which we will not be able to see very properly. And because of, we have to cancel the cycle. Sometimes the LS surge is advanced. Premature LS surge can happen even in natural cycle. Or you have already, it's a modified natural cycle. So you have, before giving your SCG trigger, there is already LS surge has happened, which you have already missed. So there are many things which happens without your knowledge into modified natural cycle, where in artificial cycle we have advantage, that because of the pituitary down regulation you have advantage, and that's why the cycle cancellation rate is definitely lower with it. It's a very important point when we consider, shall I go for modified natural or artificial cycle. Now this particular study where a modified natural cycle was used or advised to in a woman for with a regular menstruation, and it was compared with a artificial cycles and ovulation induction cycles and down regulated cycle, and what they realized, that there is a significant increase in the ongoing pregnancy rate. Also there is implantation rate much better, and also the live birth rate is significantly better in modified natural cycle in regular menstruation. So yes, we need to understand that it's a basic requirement for modified natural cycle that patient has to have a regular cycles, and she has to have a spontaneous follicular growth and ovulation, and that is going to give. This was the paper which I was discussing with you, that when you are doing a HRT cycle, and if there is a follicular growth or ovulation, what impacts it does. So whenever there is a ovulation, you have endometrial thickness, no significant difference, number of embryos transferred, no significant difference, but implantation rate and clinical pregnancy rate and live birth rate, they were especially clinical pregnancy rate and implantation rate were significantly low in patients who had ovulation or follicular growth during HRT protocol. And that's why we have to keep a track of follicular development during this particular protocol. What happens if you plan a frozen blastocyst transfer in natural cycle or HRT cycle? Does that day of embryo is going to affect? So again, this particular study has compared clinical pregnancy rate, miscarriage rate, and live birth rate, and they found there was no difference between natural cycle or HRT treatment cycle when it comes to frozen blastocyst transfer. So probably there is no change even if you want to plan frozen embryo transfer, especially blastocyst transfer. So this also paper concluded that when it is called a regular menstrual cycle, you go for modified natural. Whenever there is anovulatory cycle, you go for HRT protocol. Now this 2022 very recent study published on Reproductive Biomed online and by Dr. Yu Fu, that he wanted to compare two mainstream endometrial preparation regimen in vitrified warm embryo transfers after PGT. So now after PGT, he's sure about the euploidy status of the embryo. So then it was compared, that is modified natural cycle versus HRT. And look at the p-value when they compared clinical pregnancy rate, live birth rate, and miscarriage rate. No difference at all between natural modified cycle and HRT cycle. So that itself indicates that probably if you have a euploid embryo, protocol is not going to affect your pregnancy rate, and that's why very, very important point. And here the blastocyst embryo has been already biopsied, and they are sure about the euploid status of the frozen embryo transfer. Now again, the new area came up that frozen embryo transfer in thin endometrium, where when it is less than 8 millimeter. So what happens in these particular patients when it is these two protocols are used? So in modified natural, the duration of estradiol production is dependent on follicular growth. So again, follicle is controlling it, not you. And the levels are between 125 to 200. And if the endometrium is thin, that is 8 millimeter, even if you wish to continue or can continue for further estrogen administration from outside, you cannot do that. And so you have to plan as per natural ovulation embryo transfer. But in HRT cycle, you have disadvantage, because you can administer estradiol for a prolonged duration, because most of the time these cycles are done in a down-regulated cycle. Also, it has got an advantage of that these hormone replacements therapy also reduces the chances of follicular growth because of the exogenous estrogen. So no natural ovulation, so no interference in prolonged estradiol supplementation if you wish to give it to the patient who has less than 8 millimeter, and it is totally under your control. And that's what I kept on saying, that natural, instead of natural cycle, HRT cycle has got a better control. So friends, to conclude, if you want to do a natural cycle FET, it has to be regular ovulatory cycle mandatory. If it is unovulatory cycles where there is no follicular growth, you cannot possibly do natural cycle protocol or even modified natural. You'll have to go for HRT protocol or ovulation induction protocol. Now, this protocol, which we have understood that, how to down regulate, but the notion was, if serum estrogen levels in HRT cycles affects live birth, this was a notion. So lower estrogen levels in natural cycle have an advantage. So that was the one point where we always felt that natural cycle will give me a better pregnancy rate or better ongoing pregnancy rate. So let's see what evidence is. It's 2020, where we compared 1222 artificial frozen embryo transfer, where E2 levels more than 144, then 145 to 438, and more than 439. So three groups of estrogen concentration. And what we failed, that live birth rate in all these three groups were not very significant between each other. And that's why p-value was also not significant. So doesn't matter if your estrogen is 100 or 125, or it is even 600 or 700. Don't worry, there won't be any decrease in the live birth rate. And that's why this notion which says that serum estrogen levels affects live birth rate was evidence is against it. Now, increased risk of maternal and neonatal complication, yes, that is something which we always talk about, safety whenever new technology we accept. So HRT in comparison with natural cycle is associated with a higher risk of hypertensive disorders of pregnancy, low birth weight, and preterm birth. So all these three parameters, they are higher risk for these particular parameters. And that is why HRT protocol was associated with increased risk of maternal and neonatal complications compared to natural cycle or ovulation induction protocol. And that's why for many my colleagues and the evidence is in favor because of this safety profile, which has published recently. But we still don't know, still large number of size of studies are required to confirm these side effects. And then we can say that yes, we will follow the modified natural cycle. This was my own study where we want to also compare into frozen embryo transfer, that does the molecule of estrogen is gonna help or no. So what we did, that the ancient molecule which we are using since so many decades, that is estradiol valerate, and the newer introduced molecule, that is estradiol hemihydrate. So we wanted to compare in in endometrial preparation protocol in FET cycles. So what our results has interpreted, that when we had 103 patients and we had 72.81% total patients got a pregnancy, where a clinical pregnancy rate, okay, we'll start with implantation rate. A group who received estradiol hemihydrate, implantation rate was 87.7% versus estradiol valerate, which was 71.1%. So it was significantly in favor of hemihydrate. In clinical pregnancy rate, the estradiol hemihydrate again had a higher pregnancy rate, that was 75% versus 60% with valerate. Though it was not significant, but it was by 15%, it was higher in favor of hemihydrate. Now we wanted, our ultimate target was ongoing pregnancy rate, and we also calculated ongoing pregnancy rate, which was 75% in hemihydrate, and versus valerate, it was only 53%, significantly in favor of hemihydrate, p-value 0.0244, without compromising any significant increase in the miscarriage rate. So I think with this evidence, I was convinced, I tried to convince everybody that estradiol hemihydrate is associated. Again, mind you, it's a prospective randomized study. And also what we realized, that when I use hemihydrate, does it affect endometrial growth? Does it affect the pulsatility index in the spiral arterioles in zone 3, that is subendometrial zone? And we compared that also. There was no change, a significant change into these two parameters when hemihydrate was used and compared with estradiol valerate, no change. So we get good response with hemihydrate, plus we have an advantage of having a better ongoing pregnancy rate. So we concluded that heat side hemihydrate appears to give a optimum endometrial growth and endometrial vascularity, leading to better ongoing pregnancy rate. So I feel that not only the protocol, it's your molecule is also important, because we are talking about optimizing the results now, okay, of FET cycles. So modified natural cycle and frozen thaw embryo transfer in patients with repeated implantation failure. So now do we want to know, for those patients who has failed repeatedly, which is better? Now, what we realized that when these two groups were compared, where natural cycle protocol used, HRT protocol was used in patients with RIF, the group one that was natural cycle was having higher but non-significant difference in pregnancy rate. So again, there was a notion where we used to always feel that we whenever we have recurrent implantation failure patient, if you use a natural cycle protocol or modified natural cycle protocol, we have a better pregnancy rate. Again, the evidence is against it. Now, on what day of progesterone will you like to transfer blastocysts? I think that's my second part of my presentation, and it is important, and everything is on dependent on that second steroid which is coming in the way, that is progesterone. Now we have variety of progesterone, we have variety of dosage schedule for progesterone, we have single or double progesterone protocols, and we have minimum days of progesterone administration before embryo transfer. So many variations and so many controversies into this when we plan frozen embryo transfer cycle. So 2017 study, which gave us some insight that why the progesterones are very important for the ongoing pregnancy rate. But remember, what progesterone does is causing a desudalization. So if you have a perfect secretory change or a desudalization of endometrium, your chances of continuation of pregnancy is going to be higher. Now, if the progesterone level exposure is less, if the duration is less, if the dosage is less, you're going to have an inadequately desudalized endometrium, and because which it patient may have an implantation success, but may not be able to continue the pregnancy. So ultimately, inadequate exposure of progesterone can lead to higher miscarriage rate. So this study actually, after giving micronized progesterone vaginally of 400 microgram twice a day, the serum progesterone levels were assessed on the day of embryo transfer, and we realized that if the levels are below 9.2, there is a significant drop in the ongoing pregnancy rate. Though once you have levels more than 9.2, there is not much difference, but they realize that if you have more than 15 or 15 to 20 nanogram per ml progesterone levels, you have a much better, higher ongoing pregnancy rate than even less than 15. So patients with serum progesterone less than 9.2 on the day of ET had a significantly lower ongoing pregnancy rates. That was a conclusion, and since then we started following this. Now let's compare how many days of progesterone is required, and that's a really controversial point, because if you talk to hundreds and thousands of IVF consultants across India, each one will have something, some modification about progesterone. So fresh embryo transfer, we have, what we do is we give on this day what we call day one for the SCG injection. Then say 36 hours later, that's on day 3, we do a oocyte retrieval. Then we have day 1, day 2, day 3, day 4, day 5. So blastocyst is day 5. So ultimately from the SCG, we have 8th day when we have a ready blastocyst for the embryo transfer. Now what happens in frozen embryo transfer and current protocols is, once the endometrium is prepared, this SCG day, which we consider as day 1 in fresh embryo transfer, but instead of that, we start on little late, that is, we consider that oocyte retrieval day, the day of oocyte retrieval, where we start in fresh cycle. So we take that day as a first day of progesterone, and after 5 days of progesterone, on 6th day, blastocyst should be transferred. And this is what majority of us are following. But in 2015, there were systematic review about this, that timing luteal support. So there were 5 studies which were included. They wanted to find out what is the window of progesterone start. So 2 studies compared progesterone initiated before oocyte retrieval versus the day of oocyte retrieval, and pregnancy rate were 5 to 12% higher when starting progesterone on the day of oocyte retrieval. And that's why so many studies, and it's a routine practice to start progesterone on the day of oocyte retrieval. Now trials comparing progesterone start times on the day of oocyte retrieval versus 2 or 3 days after retrieval. Means now it is in second group, we have started at least 48 hours, 72 hours later and showed no significant differences in pregnancy. So in this group, we have given a smaller duration of progesterone exposure instead of 5 days, 5 days when you start on the day of oocyte retrieval, but still there was no difference in pregnancy rate. So what this paper opened our eyes, probably we do have even good receptive endometrium, where even if you give 2 to 3 days of progesterone and it doesn't significantly decrease your pregnancy rate. So now let's see and see those trials which was done on this particular ground. So 2016, Van de Wiswer wanted to study or find out optimal duration of progesterone administration for cleavage stage, that is day 3 embryo, 8-cell embryo. So here what they did is 150 patients received 5 days of vaginal progesterone, and then cleavage stage embryo was transferred, and in second group it was only given for 3 days, and then 8-cell embryo was transferred. What do you realize? There was not much difference in the clinical pregnancy rate, but early pregnancy loss rate, that is biochemical pregnancy loss rate, was much higher when only 3 days of vaginal progesterone was given. So that indicates that our endometrium in 3 days was pre-receptive. It was not sufficiently prepared, because of which we had lot of significantly early pregnancy loss. So when it comes to cleavage stage, 3 days is probably very inadequate for us. So that's what the conclusion of this paper. Now, what if we do instead of this particular, if we compare with fresh ET, so we increase one another day of exposure, what we call it as a 0 day of progesterone. When we start a progesterone 1 day prior of oocyte retrieval, and we increase, we keep on giving rest of the day. So now we are doing a embryo transfer on 6th day, that is blastocyst embryo. We transfer it on the progesterone 6th day. But remember, here the 0 day is calculated. So that was a modification. Then in 2021, again the new study came for the similar cleavage stage embryo, where what they did is day 3 embryo transfer after 3 days of progesterone, and then similar another group where only 3 days of progesterone was given, but embryo was not matching the day. So it was either day 2 or day 4 embryo was transferred, means either 4-cell embryo or compact cell embryo. So again, this particular group 2 was divided into two subgroups, where on day 2 or day 4 cycles, means day 2 embryo transfer and day 4 embryo transfer. So that was compared with each other. So the conclusion was significantly higher rates were noted in chemical pregnancy, clinical pregnancy, and live birth rate in group A patients who are who got at least 3 days of progesterone administration for 8-cell embryo, and when it was compared with subgroup B2, which received 4 days, and comparable between B1 and B2. So again, there were certain papers which were saying us that for 8-cell, just give a 72 hours progesterone and that's sufficient. But when it comes to frozen embryo transfer cycle, does they need more duration of progesterone administration is something what we have to look for. And the reason is that when it comes to fresh embryo transfer, you have you have corpus lutea, but when it comes to frozen embryo transfer by HRT protocol, you don't have corpus luteum, you don't have follicular growth. So the question is that in the absence of corpus luteum, do you need to give progesterone for a higher duration of time period? So this study was compared where again a cleavage stage embryo was, I think this I already discussed, that the pregnancy rate is pregnancy loss rate is higher, especially the biochemical pregnancy, if you give only for 3 days. So now with that little extra day of progesterone administration, so this study was planned in 2017, where vitrified worm blastocyst transfer on 5th or 7th day of progesterone supplementation in artificial cycle. It was a randomized control trial, and they found that there was not much statistical difference between clinical pregnancy rate when it comes to 5 days or 7 days for a blastocyst transfer. 2020, okay, 2020, this study I got it because sometimes when you are preparing an embryo, we don't get blastocyst formation on 5th day, and we get sometimes 6th day blastocyst. That is after 6 days later, blastocyst has formed. Now we are frozen. But while transferring, do you match the same embryo life when we do a frozen embryo transfer? So this study has compared that, and they documented that even if it is blastocyst form after 6 days, you can still transfer it as like a day 5 blastocyst, and you need not postpone it by one more week. Now, this was a very interesting study in 2021 by NCCO, that they wanted to find out the window of implantation by ER mapping. And ER mapping is a molecular tool which able to accurately predict endometrium receptivity status by transcriptomic analysis. So this was a retrospective study where 2,256 subfertile patients were selected, and they realized out of this such a huge amount of patients, out of huge size of patient, 34% had a displaced window of implantation, and that was a pre-receptive side, means 25% were having pre-receptive endometrium, so transfer has to be little later. So a significant increase in pregnancy loss was detected in the group of transfers that deviated from estrogen receptor mapping recommendation compared to transfer performed within AR mapping window of implantation. So if ER has given you mapping for window of implantation, if you do that in that particular window, it is associated with a reduction in the pregnancy loss, because remember, ultimately it is the ongoing pregnancy rate is most important. Most patients are receptive between 5 and 6 days of progesterone intake. So look at this diagram, this bar chart, where after 5 days of progesterone, from 5.5 to almost 6.5 to almost touching to 7. So look at this green line, which is receptive endometrium. So your endometrium is most receptive after 5 days. Then it keeps on, then it is steady on 5th and 6th day. And again, it is slightly dips on the 7th day, that is 6.5 day. And again, by the evening of 7th day, it dips. So this is very important evidence, and that gave us some idea that at least it will give progesterone for little more days. That is, maybe for instead of 6th day, you give it for 7th day. Okay, but this study also gave us idea that look at these 2.5, 3 days, 3.5 days of progesterone administration, still you have a presence of receptive endometrium, and that is why many of you will agree that even with minimal of 72 to 48 hours also, 48 to 72 hours also, you may get implantation, successful implantation and pregnancy continuation. But it's not true with the majority patient. If you look at it, is below 20% incidence of successful implantation in this group of patients. So our proposed theory was that why can't we give more progesterone before we do a blastocyst transfer? So what we do and what we try to do and decided to do a few years back, that we match and mimic the fresh embryo transfer cycle. So what happens in fresh embryo transfer cycle? You have a multiple follicular growth, you give SCG. So what happened in SCG, that as soon as you give SCG, 12 hours later, there is a presence of progesterone in the circulation. So what happens from the time of SCG trigger till the time of oocyte retrieval, you have 35 to 36 hours. There is a progesterone production from your endogenous source, which is a follicle, which are developed follicles. And then that is missing into the frozen embryo transfer cycles, especially when it is HRT protocol. So in preparing the HRT protocol, FET protocol, then you have to understand there is no corpus luteum. So no progesterone is going to come. So what you do is, as soon as you find out the endometrial picture is better, then you start giving progesterone. And that's what I named it as 0 day, whereas like SCG, you give a night dose of progesterone in the night. So one single day of progesterone on the night of decision, and from the next day, which is actually 3 times a day, we are giving progesterone. That's your day 1 of progesterone. So remember, I do consider that is a 0 day. Now it's completely on you. You call this 0 day as day 1, or you call it as a 0. Accordingly, the next few days will change. So if I consider this as a 0 day, where I'm giving on 0 day night dose and 3 times a day from first day, then if I match this all these days, then my blastocyst transfer is going to fall on 7th day of progesterone. Now, keeping this in mind, we wanted to study that with this much minimum progesterone, what are our results? So we did this estradiol hemihydrate validate study with the same progesterone administration. 7th day, we did a blastocyst transfer, and we got this good results of implantation rate of 87.7%. Even you use valley rate, the pregnancy rate, implantation and clinical pregnancy rate were 60-71%. So it was far much better. Now the whole intention of this duration comes down to not clinical pregnancy rate or ongoing, implantation rate, but it is most important for me is a miscarriage rate and a biochemical pregnancy rate. And look at those, no significant change after you give for 7 days of progesterone, and on the 7th day you transfer blastocyst. There is no change into the biochemical pregnancy rate and I mean they are the most lowest. Even in another our trial where we wanted to do a fresh transfer versus frozen embryo transfer, which is better, even in those FET HRT protocol was used, and there also we followed the same protocol, and we documented that the biochemical pregnancy loss rate was only 6%. So if I would have given that 1 day extra progesterone, by the previous theory, I would have been in a post-receptive phase, but I would have had more miscarriage rate. But no, I did not get that. So probably looking at those study which I mentioned where they charted the window of implantation. So you can transfer from 6th day morning of progesterone to 7th day evening. You have 48 hours window. You can transfer the blastocyst embryo. So no need to get panic that somebody is doing on 5 days later, 6 days later, 7 days later. What should I follow? Remember, window of implantation is 48 hours, and that's going to be better if you have these 48 hours detected well. So according to this all evidence, 6th day morning, remember 0 day where you give 1 dose, and I'm talking about HRT protocol. So when you give 0 day 1 night dose, and then first day you give 3 day times like that, and then 7th day you can transfer blastocyst, or you can transfer it on 6th day also. So now let's understand these progesterone concentrations and on the day of embryo transfer, does it have an impact? So look at these values. When the progesterone was less than 10, the pregnancy rate was 34%, but the moment progesterone was more than 10, it was 48%. The same happened with live birth rate, almost 70 to 80% higher when progesterone levels was more than 10. So now the data which I presented to you says that giving more progesterone will be able to achieve more better serum concentrations. And once we have a better serum concentration, then we have a better live birth rate. Suppose if you don't have on the day of embryo transfer sufficient progesterone levels, don't worry, don't cancel. Now we have evidence like these papers where if you have added intramuscular progesterone 40 milligram daily, this was a study done by Hongya and Gao, where they do have progesterone 40 milligram injectable. If you have given it daily, even from the day of embryo transfer, there was not much difference into the miscarriage rate. It was only 14.7% to 16%. So there was not much difference between miscarriage rate. So you can still rescue the cycle by giving intramuscular. Or now we have in India daily subcutaneous aqueous progesterone available. So even if you have started on the day of embryo transfer, if the progesterone is low, if you started giving her daily subcutaneous progesterone, still the outcomes, including the miscarriage rate, has no significant difference. Still you can achieve what you would have achieved when the progesterone levels are better. So you have rescue situations when you have low progesterone levels, but the only fact about natural vaginal progesterone is that because it is uterine first pass effect, you have an endometrial concentration. Probably your serum levels may not reflect your endometrial concentration, but for all practical purposes and evidence, 600 to 800 milligram per day in 2 to 3 divided doses was used till now for all research purposes. But I think this was the evidence which I wanted to quote, and I use it in my practice, is 2018, when 1188 patients received 1200 milligram per day of vaginal progesterone was compared with 900 milligram. They documented that clinical pregnancy rate was much higher in 1200 milligram, even comparison with 900 milligram. So you give higher doses, don't worry, it's not going to affect your pregnancy or not going to decrease your clinical pregnancy rate. In fact, it's going to help you to achieve more better pregnancy rate. Now we're in an era where we have dydrogesterone available, and we have Lotus trials supporting this, that it is one of the best molecule orally available. So suppose I combine both progesterone, that is natural vaginal progesterone and dydrogesterone, does it have any impact? And that's a mid-run trial which was done in 2021. Again, if you look at the p-values, all significant. Live birth rate significantly better with the combination than only natural vaginal progesterone. Look at the miscarriage rate, significantly less when you have added dydrogesterone with vaginal progesterone. The birth weight in singleton, if you look at those birth weight, it is more with natural vaginal progesterone. It is in a normal range between when combined. So no, not inferior this combination when compared with natural vaginal progesterone. So you can add oral dydrogesterone and reduce the pregnancy rate. So to conclude, in frozen embryo transfer cycles, luteal phase needs to be supported irrespective of endometrial preparation protocol. And when it comes to progesterone, it is the best molecule to support luteal phase. And evidence does says blastocyst transfer should be planned on day 5 of progesterone, but newer evidence is suggesting that if we transfer vitrified thawed blastocyst on 7th day of progesterone, and if you want to do a cleavage stage embryo transfer, then 5th day of progesterone, when 0 day is the one where you used to give a night dose, that leads to significant reduction in the miscarriage rate, and the miscarriage rate is only between 6 to 7%. And dydrogesterone shows no difference in outcomes of pregnancy when compared with natural vaginal micronized progesterone. That was proven by Lotus 1 and Lotus 2 trials. Also, frozen embryo transfer cycle is freeze-all way is way in the field of assisted reproduction, especially for hyper responders and certain group of normo responders. So we need to master now in endometrial preparation to prepare the soil for best quality of embryo transfer. In modified natural cycle protocol is associated with a higher clinical pregnancy rate and live birth rate in comparison with artificial cycle, especially in patients with regular menstruation. But in anovulatory patient, either you go for GnRH agonist down-regulated cycles, or you can go for a ovulation induction cycle. And day 7 of progesterone is the ideal for blastocyst transfer. So with this note of some take-home messages, I thank you all of you for the patient hearing, and I hope that I sorted out the confusion in your mind looking at the evidence at this moment. So probably in future we are looking at those studies which will be more depth and give us more depth knowledge into this field of endometrial preparation protocol, and again it will further increase our expertise. So thank you very much for the patient hearing.
Thank you, Kundan, for that elaborative and exhaustive talk on the progesterone, especially for the frozen embryo transfer. So I think you have covered almost everything, and we have got few questions, but most of the questions is not related to the as such for what you are talking. It is related to the estrogen in routine ovulation induction also. I think if you have time, can you, Vasu, can you go for the questions?
Yes, I think we can take questions.
So first question is, what should be the endometrial thickness prior to ovulation or giving beta HCG injection? That is for routine ovulation induction, the question is.
Okay. So ideally, if you look at the percentage of implantation rate according to the thickness, so there is a significant decrease in the implantation rate once the endometrium is below 8 millimeter. Okay. But 8 to 9 millimeter, there is not much difference. When I say difference, it is statistical significant difference. So the best cutoff is that minimum should be 8 millimeter. Now below 8 millimeter is a patient of thin endometrium. So even if you have 7.5, you are to give a trigger because you cannot wait further, you will still get a implantation rate. The only problem is that the pregnancy rate is going to go down a little bit in comparison with what you would have got it beyond 8 millimeter. So I think the answer to the question is 8 millimeter should be the better cutoff where we decide. Now, suppose you have a follicle which is ready and I want to give a SCG and your endometrium is less. I feel that rather than offering a lower pregnancy rate, why can't we just wait and do, maybe you can give antagonist and stop premature LS surge and give some more estrogen for a few more days and increase. That can be the rescue situation. Or you can just cancel it and go for down-regulated HRT protocol where you have an advantage of giving more estrogen for a longer duration. And I'm sure that this patient might do much better in HRT protocol when you give more estrogen.
Okay. So next question is that how do you overcome the poor endometrial thickness, which may be due to, which may be for FSH and LS receptor polymorphism? It's
Can you
a
repeat
quite
it?
new
I
thing.
missed the word. Can you repeat in FSH polymorphism?
Yes. FSH-LH, if the endometrium is poor and if it is due to FSH-LH receptor polymorphism, how do you overcome it? That is a really new thing, and it is still very few papers have come.
Yes. Now remember, I think it's very important. Now, when there is a FSH-LH polymorphism, obviously your exogenous FSH is not going to help. And what happens is the ovarian response is poor in this group of patients. So in this group of patients, when I think they are talking about endometrial preparation protocol. Am I right, Facey?
Maybe.
Yeah, maybe. Because then in this protocol, the answer is very simple. In this scenario, you go for a HRT protocol because you're no more dependent on the follicular growth. So you don't plan for modified natural or your ovulation induction cycle. You go for straight away HRT because exogenous estrogen is going to develop the endometrium irrespective of the FSH polymorphism. So HRT protocol is going to be better.
Okay. Next is when should we start estrogen in ovulation cycle? I think the question is regarding the routine ovulation induction cycle. So that is a little controversial thing whether you start at all. There are a lot of people who feel that if you start, that will reduce the suppress the LH. So I don't usually start before ovulation occurs. What is your opinion on that?
I feel that when you are planning a ovulation induction cycle, you want more endogenous estrogen that is coming from the follicle. So you want that response. Now, only role is suppose, as we discussed in the first question, that if the follicle is ready 18 to 19 millimeter, and obviously the LS surge is going to happen after that. So suppose your endometrium is lesser and you feel that you are documented this patient had a better endometrium in previous couple of cycles. So here what you can do is you can give antagonist, avoid this LS surge, and here you can add exogenous more estrogen and wait for more 2 or 3 days. Once you see a better endometrial growth, you will get that endometrial growth once you add exogenous estrogen and little in a higher dosage, not in a very low dosage like 4 milligram, 6 milligram. Then you can add more estrogen into it and you have bought little more time and preventing the LS surge. So here you have to take the help of antagonists to prevent us for 3, 4, 5 days for prevention of that LS surge. And then once the endometrium is better, then you don't give SCG trigger there because probably the time has gone. So here you can, just like what we do in HRT, you give progesterone, you start progesterone from consider night dose as a 0 day and 7th day you can transfer blastocyst. So you can rescue, and that is the only place where I feel that you can utilize estradiol. Otherwise, no role of giving estradiol before follicle is below 18 millimeters. So I don't recommend that. I mean, that estrogen is not going to help you to
Improve the pregnancy rate.
Yeah.
Especially because if the follicle is not ready, so follicle has to produce estrogen. If it is not there, by just giving that, it may not be useful. Plus, that may suppress the LH surge also. And next is an interesting question. I think minimum and maximum number of days of estrogen exposure for FET. Is there any minimum?
I can tell you my experience because I am using a lot prolonged estradiol protocol since almost now it is 10 years I'm using. So what we realized is that you can give, the only thing when you want to give estradiol for a longer time, you have to have a down-regulated pituitary. Means you have to use or do it in a down-regulated cycle by giving GnRH agonist depot. So now you have a full privilege. Once you do a down regulation, you have privilege to give. Now, if you ask me in the literature has documented in 84 days they have given into few patients. So that maximum you can give. But I felt that even in thin endometrium patients, I have given it in my practice for almost more than 50 patients. We have given it for 38 to 39 days. And in those protocols, we have achieved ultimately close to 7.5 to beyond 7.5. Minimum 7.5 we have achieved into thin endometrium patient, and we have documented such 23 clinical pregnancies into 30 patients where we have used and given estrogen for almost 30 to 38 days and we have documented clinical pregnancy rate in this patient who has failed implantation in the previous cycle, and they have documented pregnancy with these protocols because of thin endometrium. So you can give it longer, but down regulation is compulsory in these patients.
Okay. Next is that if the how do you manage a persistent diffuse polypoidal endometrium hysteroscopic polypectomy done twice?
Right. So I think this is more like a higher progesterone. It's a cystic hyperplasia, and that is because of hyperestrogenemia. This typical picture comes because of hyperestrogenemia. So I think what I recommend them, that before you plan for frozen embryo transfer, you have to suppress these estrogen levels. So you give more progesterone therapies, cyclical progesterone for at least minimum 3 cycles. So there will be a lesser estrogen in the circulation, and this hyperplasia will be prevented. And you will realize that after 3 cycles of progesterone therapy, so down regulation, you will not see this kind of cystic spaces in the endometrium. Now, second point, I have noticed this, that in prolonged estradiol level, we do get this kind of picture where we start seeing a cystic glandular, glands, endometrial glands are becoming cystic because of hyperestrogenemia, because we are giving it for a longer duration. But believe me, my experience into this success rate of giving 73-75% in frozen embryo transfer for prolonged estradiol, these things do not interfere into implantation. They do not interfere into implantation. Even if you see some 3, 4, 5 cystic glands, into the endometrial core, when the endometrium is prepared, it doesn't interfere into the implantation. So ignore. Only if it is too much cystic hyperplasia, you suppress it with progesterone therapy and then start preparing endometrium.
Okay, then next is that which progesterone do you use? Maybe FET cycles.
Yeah, I use natural vaginal micronized progesterone. I use it 400 microgram 3 times a day. So that comes to 1200 microgram per day. Along with dydrogesterone 10 milligram TDS, that is 30 milligram per day. I use these 2 progesterone together.
Is it used before transfer or after transfer only?
No, this is before transfer. So the
both dydrogesterone.
My proposed theory is that you consider 0 day when you give a night dose. So I give 400 microgram micronized progesterone as well as dydrogesterone 10 milligram night dose. That's single day on 0 day, single dose on 0 day. And first to 7th day, I give 3 times both the progesterones.
Okay. It is said that no amount of exogenous estrogen can. It is said that no amount of exogenous estrogen can improve endometrial thickness. Maybe that question is little vague.
The question is like this, that more progesterone is harmful for implantation? That's what the question is?
No. Exogenous estrogen, it is said that no amount of exogenous estrogen can improve endometrial thickness. Maybe in some cases.
You mean to say the one which we said that you want to buy some time and you can give. But I think what I realized, generally this will happen when your follicle is defective. Remember, so it will be helpful. So you have to have a estrogen levels with you. My point is, suppose a follicle has developed. Now this follicle is defective. It has not produced sufficient estrogen, and because of which the endometrium is low. So if you check the estrogen levels on that day when the follicle is 18, 19, and estrogen levels are below 100, that is 60, 70, 40, 50, means the follicle is defective. Endometrium is not a problem. Now in this scenario, you give antagonist so that you prevent LH surge, and now you give exogenous estrogen because you are increasing circulatory levels of estrogen, and now only this group of patient you will see actual increment into endometrial thickness. Okay, but if you have already good endometrium, a good circulatory levels of estrogen, the question is right that exogenous estrogen will not benefit. So serum estrogen levels is going to help you in this.
Next one question that is, you had already told, can we give hemihydrate for preparation, and what is the advantage? I think you had already told that. Then next is 2 questions are related. If lining is not sufficient in spite of sildenafil and estrogen, what can we add? Or another question is how to manage thin endometrium in spite of PRP and adequate estrogen support, and what the allowed estrogen dose for endometrial preparation. That part is okay, but the other is a difficult question. even with PRP, what can be done?
Yes, I think these are the situations where PRP plays a very important role. Now, two things are very important. Suppose the endometrium is thin or not adequate, that is, say, maybe 7 millimeter or 7.5 millimeter, and it is stagnated there, but you want more endometrial thickness for successful implantation. So in this scenario, you can use a rescue situations like PRP, because PRP has shown that after the first intervention, then 48 hours later, you do a second intervention, that is second PRP infusion. Then 48 hours later from the second intervention, that is fifth day from the first day intervention, then you will see an increment into endometrial thickness. So minimum 5 days are required. So that much time you will have to wait. Don't expect the endometrial thickness to rise within 48 hours from only single infusion. And that's the evidence. Literature has clearly given evidence that you need to give 2 PRPs, and then around 96 hours later from the first intervention, you will start seeing the changes into the endometrium. So that is the only thing which can be helpful to rescue. Suppose you have not done the hysteroscopy in this patient, and you don't know the endometrial fibrotic status in the endometrial cavity. There you stop the cycle, let her get menses, put the hysteroscope, look at for fibrosis, remove the fibrosis, do a lateral metroplasty, and then repeat the cycle of endometrial preparation. So these are the two things which you can do it in thin endometrium when it is not responding to your sildenafil or estrogen.
Okay. Then next is that along with progesterone given for luteal phase support, using antagonist plus IUI. So that means in IUI cycle, if you give antagonist, whether you have to give estradiol also for luteal phase support.
No, you don't need to give estradiol in antagonist, because antagonist is it's a competitive inhibitor. So it doesn't have a longer action like agonist. So you don't need to give it.
So I think should estradiol be started in all patients or only for those with poor thickness? That we are already discussed. Then role of progesterone for estimation on day of FET.
Sorry, say it again.
Progesterone P for estimation on day of FET.
P for estimation. I think that's what we discussed, that the circulatory levels of progesterone on the day, if it is possible and feasible in your city, you must do it. Or at least what we do it on the 1 day previous day. I mean, previous day of embryo transfer, so that the night before embryo transfer, we have the report of progesterone, and we have enough study and very good study which says that if the progesterone concentrations are beyond 20 nanogram per ml, your ongoing pregnancy rates are significantly better. Okay, and they significantly fall below, or miscarriage rate increases significantly if they are below 9.2 nanogram per ml. So even you have window between 9.2 to 20 where you can do transfer, but you can expect some amount of reduction in the ongoing pregnancy rate. So we try and see to maintain above 9.2. That is very important.
So one last question. What is opinion about the subendometrial stem cells?
I think there are two varieties of it. Now, a group of a Spanish group has done this study where they have done a stem cell infusion angiographically into the uterine vasculature, because of which they did mention in patients with Asherman syndrome who had a thin endometrium, they did angiographic, systemic administration, they did it specifically into uterine vasculature, and they have documented that almost 20 to 30% pregnancy rate with those kind of stem cells where you have a thin endometrium due to Asherman. Now, these are the newer protocols where we are injecting stem cells into the subendometrial zone. But believe me, this is still under experiments. We have very few case reports. It is not a guideline to be used about injecting stem cells into subendometrial zone. So it is still under the experiment. So please, you have to cautious and you have to counsel your patient. And if patient's consent is very important, because tomorrow you never know that these things, they read it and this was under experiment, they can file a sue or case against you. So please, you have to mention that this is under experiment. I have never done it subendometrial injection of stem cells yet, but there are only literature also, have a fewer reports, but probably maybe after a decade or so, after 10 years later, we may have established technology with that. So I think still it is.
What is your experience about GCSF?
Yes, I think that is something which I really like to emphasize, that one molecule which can really helpful in many patients, especially when you have an endometrium which is stagnated between 7 to 7.5 millimeter. There, if you add 100 microgram of GCSF subcutaneously daily, then after a week later, you will notice increment by almost by mean of 1.84 millimeter. And this is our own study has documented. So you can cross that 8 millimeter barrier and you can safely have an endometrium after GCSF administration for minimum 6 to 7 days, but only 100 microgram per day subcutaneously, because if you give 300 microgram, it is associated with severe body ache, and patient do have unbearable body ache where you have to use NSAID. So don't use it. Is too high dose for systemic administration. It is only utilize this in cancer patients, but not in fertility patients.
Okay, I think now we have covered almost all the points in the questions. I think, is there any other questions also?
No, sir. No, sir. No other questions.
So I think not only the FET part, the endometrial part, the endometrial thickness part, preparation, even for in the normal ovulation patients and for the persistently regular endometrium and FET cycles, all the aspect has been covered well by Dr. Kundan. I think as a lot of things, there is some people do it little differently, but as a whole, what the routine consensus or routine what people is doing has been covered. So I think as newer literatures comes out, studies come out, find refinements in this adjustment of the protocols for endometrial preparation will go out, so that we can expect at least slightly that will improve the pregnancy rate in each cycle. Thank you, Kundan, and thank you, Corona, for this great initiative.
Thank you so much, sir. Thank you, Kundan sir, for wonderful session. Thank you, Fesi sir. Thank you so much.
Very much, Dr. Fesi, for a lovely interaction. So thank you very much, and meet you soon, probably in IAG or AICOG conference.
Okay.
All right.
Okay, is it offline? 1 minute offline?
Yeah. Thank you. Thank you so much.
Abhishek, this is offline.